Good evening. Welcome to Backstory with Joan Goldstein. I'm Joan Goldstein, and my guest this evening is Barry Rabner, the President and CEO of the Princeton Healthcare System. Good evening, Barry.
Hi, thanks for having me.
My pleasure. I discovered it's been a year since I interviewed you for the Montgomery News, so we have a lot to catch up on. I thought we'd talk a bit today about the national scene first, about what's happening with this national healthcare debate. About a few weeks ago, I went to a town meeting that Congressman Rush Holt held in Middletown, New Jersey, and we couldn't get inside the hall, so we had to be outside the hall, and Maggie and Dan and I were outside listening to his opponents and his opponents' followers with their signs. Here's what some of the signs said. Government Healthcare Hotline, 1-800-YOU'RE-DEAD. If the plan's so good, you be the guinea pig. Take back America. There's no free lunch. The taxpayers are carrying the whole load. And one candidate who spoke against this said, they tell you about the uninsured. What they don't tell you is 20 million are illegal immigrants. The pro people, the people who were for the health care plan, had signs that said, good solutions come from respectful discussions. And a comment made about a Republican candidate speaking by a non-Republican, he said, here's a guy running for office on the premise that we don't need government. And finally, a pro person said, we all benefit when others are healthy. So what is all this excitement about? What is all this, from a hospital president's point of view, what do you think is going on?
Yeah, it's interesting to me. You know, my initial reaction to the quotes and the signs and that you just shared is people trying to summarize in a sentence or two something that's enormously complicated and enormously important, and they can't get it that way. You know, it requires time and thought. And I try my best to pay attention to what's being considered, but it's still a work in progress. And it's no one knows what is likely to come at the end of it. But whenever I think about a problem like that, I start with trying to understand what we're trying to accomplish. I don't usually start with trying to figure out what's wrong with the other person's argument. And when I do that, I start with some of the things that are referenced in there. There can be debate about the number of people who don't have insurance. 48 million, 40 million, 28 million. It's a huge number of people who aren't getting the care that we're capable of delivering. You know, I think about how it works just here in New Jersey. We've got 74 hospitals, and last year those hospitals provided $1.5 billion in free care. The state, with the financial challenges that it has, is only able to cover about a third of that. In part, the result has been that more than half of the hospitals in the state operate in the red. So it has created a problem in terms of the strength of the hospitals and their ability to deliver care to everyone, not just that segment of people who don't have insurance. Mm-hmm. And then I think about the people who come into the emergency room. Now, we're fortunate in that, given the location of our hospital, the number of people who do not have insurance is less than it is in a lot of other areas in the state. But still, we provided probably $15 million in free care last year. And the people who are coming in are often coming in through the emergency department. They're very sick. You know that if they had come in to see a doctor earlier on, then the problems would have been much easier to address. The quality of their lives would have been better. The cost to society, because we're providing the care. If they come in, they get the care that they need. The cost is enormously more than it would have been had they been taken care of properly by seeing them earlier on.
Right.
It has to be dealt with. It can't continue. Yeah. We have the ability to do that. You know, just one other example that just sticks in my mind. Our system provided about 1,200 free or very low-cost screening and education programs. There were 38,000 people who participated. We had a health fair in one of the local schools. 600 people, families,
Oh, yes.
showed up
Yes.
for the most basic care, for healthcare screenings, diabetes screenings, high blood pressure, prostate cancer, breast cancer. That's how they get their routine health care, through a screening in a school that happens once a year, and get in a line with 600 other
Yeah.
people.
So that's an
It can't
indicator.
be that way.
That's an indicator of these. This is the population that's not getting the care that they need. It reminded me that, and I mentioned that to you a little earlier, in England, a long time ago, and I won't say how long ago, but in the early days of British National Health, was in an accident. I was a bicyclist. I was a youth hostler, and at those days we didn't wear helmets, so I get thrown off my bike, and the British Army scoops me up off the ground and brings me to a hospital. I spend a week in this hospital. I've had x-rays of the skull, and so forth. And at the end of that stay, I owed them 40 cents for some drugs that were not covered, so they told me. But also, I wasn't a sociologist yet, but I was, as I say, a budding sociologist. So I used the time I lay in the hospital bed to talk to the other patients about how did they feel about this national health system. Now, it turns out that a lot of those patients, of course, they were women because the women's ward, were what we call working class, or you would have called working class in England, people who are not well off. And several of them said, you know, because of this national health system, I'm able to get this operation that I needed, but could not have afforded to pay for before. So for them, it represented an upgrade in their health. It was, otherwise, they would have lived in pain or disability without being able to do anything about it. And that stuck in my mind, in my memory, all these years. That isn't that another area that we have to think about. Some people are getting too little care or not getting care soon enough. And is that the population we're trying to help now? Or isn't it everybody who needs to get more?
Yeah, you raise a lot of important issues. You know, the first thing that occurs to me is when you talked about you had to pay 40-some cents for your care. Somebody paid many thousands of dollars for your care. You know, they've organized their care delivery in a way where that burden is shared broadly, and you were able to get the care that you needed. But it cost obviously a lot more than that. One of the issues we have to deal with here is not just how much care might cost someone and whether they're insured or not, but we've got to really make sure that people are, that our society, that our country is getting value for the money that it's spending. We are if you look at international data and compare us to others, we cost a lot of money to achieve in what in many cases is a very modest level of clinical care. You know, we pay a lot for what can be very modest outcomes. So it really comes down also to a question of value. And are we getting what we're paying for? And I think in many cases the answer is no. There's a huge amount of waste in the system. There's a huge amount of inefficiency. And some of it is caused by the odd ways in which the system is structured, and care providers, hospitals, doctors, pharmaceutical companies, equipment manufacturers, device manufacturers, because of the way we're all being compensated. And we've got to change the system so it is more rational, so that we're all lined up around things that really matter, like efficiently delivering on high quality care, and not all these odd incentives that have providers running off and either being inefficient or delivering care that's very costly and quite modest in terms of its quality. So you have to do both. We've got, and that's why this is so complicated, because we've got to figure out how to provide care to people who need it, and we have to figure out how to get it to them when they need it, which then really does relate to cost, because it is less costly to provide timely and high quality care. And then we have to figure out, from a more global standpoint, how do we reduce our healthcare costs so we're getting value for the money we spend, so that the products and services we produce don't have this huge anchor on them in terms of the component of the cost related to healthcare, so that we can compete even internationally, which is, to me, another reason why everybody has to care about how we deal with people who don't have insurance and don't get the coverage they need, which doesn't deal with the fact that there are people who lose their insurance when they become ill, people who can't get insurance because they are ill, and we need to stay focused on those handful of issues and the solutions to them. The other thing that always occurs to me, both working at the hospital and elsewhere, is criticizing's easy. You know, coming up with solutions is very, very hard. And you know, if you don't get it right the first time, which by the way is most often the case with complicated problems, you just keep hammering away at it and you just keep improving it. But to stay away from these problems because the solutions are complex is wrong in my mind.
Wonderful. Okay. Didn't you tell me just a few minutes ago that you're going off to China soon to lecture to the Chinese?
I am. I was telling you how excited I was about this. I was invited by, it's actually called Peking University in Beijing, to present the lecture to hospital CEOs in China. All of the hospital CEOs in China are physicians, and although I'm sure well medically trained, their administrative experience and education is modest. So a program has been developed to bring executives, mostly from the United States, healthcare executives, to talk about the good things that we do and how we do them. And I was invited to come and talk about how to think through the development of a new hospital strategically, and then how to think about all the issues relative to sizing and then the design and actually on through the construction, because as you know, that's something that the Princeton healthcare system's been working on for a couple of years. The other thing to me that was very interesting about the invitation to do it was they have their own stimulus package in China, and they've allocated somewhere around $180 billion for new hospital construction. I don't know the period within which they intend to spend that. So they're working hard to think through the most effective way to invest that money, and I'm going to have a chance to give them my 2 cents on things to think about. So I'm really looking forward to it. It's going to be great.
We have to hear about that when you come back, too, what kind of questions they want to know, and what happens, you know, if you go to another country and you have to consider what happens if I get sick in this other country, what is their healthcare system like? I know when my cousin and I went to Romania in 2004, we received some kind of a paper that said, if you get sick in Romania, leave the country. That was not very cheery. Well, let's segue into what you're doing with the Princeton Hospital Medical Center. You're making big changes. You've been there, what, 7 years at this point? Yeah.
That's right.
How do I know? Because when I interviewed you last year,
it was 6 years.
I can add and subtract, right? So you've been there 7 years, and your main goal at this point has been to not just move the hospital, but also create a new hospital concept altogether.
Yeah, so probably about 5 years ago, we set out to develop a strategic plan for our system. And it dealt with a whole host of quality, service, and financial issues. But one of the discoveries there was that we needed to replace the current hospital sometime in the future because we simply didn't have the space, would not have the space necessary to address the growing population, the aging population that we've traditionally served, introduce new technology, change the way we deliver care. As we thought it through, we worked with the community to understand whether we could address that need on the current location and expand there, whether we needed to relocate. And if anyone is familiar with our current site, expanding there is not a reasonable option. So we identified a new site on Route 1 in Plainsboro, 2.5 miles from Witherspoon and Nassau, 3 miles from the current hospital. It's 160 acres. That was interesting because originally we were looking for 50 acres because we didn't want to run into the same problem we have now 40 years from now where the demand to expand is there and we didn't have the capacity to do that. We ended up with the 160 acres because we just loved the site. It was more accessible to more people. It's, let's see, it's closer to 70% of the people that we've traditionally served. And it gives us an opportunity to create a health campus not simply replace the hospital. So for example, our nursing facility, Merwick, will be relocating to the new site. In fact, it's under construction, and it'll have 200 beds and some wonderful support areas. The hospital itself will be about 700,000, slightly under 700,000 square feet, with the ability to expand to almost 2 million. And we'll have a 122,000 square foot medical office building. We hope to have a fitness and wellness center, not unlike the one that we have in Montgomery now. We have an education center. One of the things that I'm particularly proud of are the environmental features that we've designed into the facility. So for example, we're working with a company called NRG to build a cogeneration plant that'll convert natural gas to steam and chilled water and electricity, which in itself will dramatically reduce our carbon footprint. And one of the other really neat features, and there are many, and I'll talk about it until you tell me to stop. But the other one that's just really neat to me is where we had intended, where we're putting our employee parking lot, we're going to be erecting a field of photovoltaic cells to convert sunlight to electricity. And it's a very clever design because there'll be a number, probably 15 or 20 columns, about 15 feet tall. And on the top of each column will be a 30-foot by 30-foot array of solar cells. And they'll collect power. It'll produce up to 15% of the electricity that we need. You can park under it, get out of the sun, and they'll even have outlets in the columns so that when more people have electric cars, they'll be able to charge while they're at work.
Okay, let's just bring it down to, let's say, one person. The year is 2011. That's your projected date, right?
That's it. We're moving in end of 2011.
And 2011. And an individual, let's call her Sally, goes to the hospital. What would be different about her experience going to the new hospital, as opposed to what would happen today?
I like that question a lot because we've thought through the design of the hospital with that question in mind. So the first thing is if Sally's comfortable doing it, she'll be able to register for an admission or for an outpatient visit on her computer at home. She'll come into the hospital with what I imagine will look like a boarding pass at the airport, and there'll be a scanner so she can go to wherever the care she needs is. She'll go there, someone will greet her, take her boarding pass, if you will, scan it, and we'll know everything we need to know and get you on your way for your care. If you're uncomfortable with that, we'll actually have people who will help you get through the system. So it starts with that.
So part of the processing is actually the entry itself.
That's
less waiting time.
Starting at home. Because
starting at home.
In fact, we won't have a scheduling area. We won't have registration.
But if someone doesn't have a computer, then
you'll be greeted at the door. You'll be escorted to the area in the hospital that provides the care you need, and there'll be someone there who will be able to handle all the bureaucratic stuff, ranging from confirming what you're there for to dealing with insurance issues and all those other things. But because of the sophistication of the information technology, we're able to do it either at your home or much more efficiently at the hospital. I think the next part of your experience in the hospital is we all like to talk about the hospital being organized around you and that it's patient-focused. Historically, and unfortunately more still today, hospitals are organized around staff and physicians. And they're often old and built incrementally, over time. So when you come in, nothing ever feels like where it's supposed to be. So you go there for registration, you go somewhere else to see your physician, somewhere else for a lab, somewhere else for pharmacy, and you're spending the whole day seeking out care. We've tried to organize it in the new facility where all of the services that you are likely to need are aggregated together. So in the front of the patient tower, in the main concourse, we will have what we're calling portals of care. So say that you're coming to the hospital with a problem related to your heart or your lungs. There's a portal called the Center for Heart and Lung Care. And through that portal, we've organized most of the services that you are likely to require during that stay. And then another example is the Cancer Center. All of the services that you're likely to require if you're receiving cancer care are aggregated together. Now, there are exceptions so that when there's very expensive equipment, equipment costing tens of millions of dollars, that'll be organized behind those portals so that it is easily shared by the people who are using the hospital in an efficient way. So we're trying to be cost effective. We're trying to make the experience a lot faster and a lot simpler and a lot less anxiety producing.
That would be helpful.
One of our mottos is in the hospital is everyone there is under stress. What people, it's obvious to people that visitors and patients are under stress. What folks may not appreciate is everybody who works there is under stress too, because we take what we do very, very seriously, and people have problems, and it is stressful. So anything we're able to think to do to get the building, with whatever its limits are, to reduce the stress that people feel when they're in the hospital, we've done. So if we can make wayfinding easier, if we could reduce the amount of time you're there, if we can give you the feeling that you're actually in control of something, as opposed to that feeling when you come into the hospital where you're giving up all control, then it'll make your experience better, and that'll make your outcome, your clinical outcome, better. I think another thing that you'll see when you're moving through the care is that something which may sound modest to you is that 90% of the space in the building will have natural light. And it's funny because when we were designing the building, I went with a team of physicians and others to visit the newest, best hospitals in the country to see what ideas we could borrow and which ones we should avoid.
I think you also told me that this was, as far as you knew, this was the only one that was actually being designed from the bottom up.
Not the only one, but it's unique. I shouldn't say it that way. It's much less common than I would have originally thought. Because basically what happens is there's such huge investments in hospitals that it's more likely that they'll just be added on to than that they'll have the chance to start from the ground up, which really is great for us because we can actually put things where they need to be, not just for the patient, which I was describing, but when you think about the nurse. We have to figure out how to reduce the amount of time the average nurse spends in what we call hunting and gathering, and give her the time she or he needs to actually be with the patient in the room.
So it's a much more conscious attempt to be efficient with everyone's time and energies, which more so than most hospitals, which evolved over time without thought being given to.
And it goes back to our earlier conversation, because we're talking about how do you reduce healthcare costs, and one of them is through an investment in information technology, an investment in new physical plants.
You started working as a teenager in a nursing home, so you have been around healthcare for a good part of your life, and apparently it really interests you. So now you want to get into this business called evidence-based design. What does that mean exactly?
Yeah, that's been of huge value to us, because when we set out to design the new building, we had very measurable objectives for what we wanted the building to help us accomplish. We wanted the building to help us reduce infections. We wanted it to help us reduce falls, errors, reduce our operating costs, improve the quality of communications between staff and patients and families, and another dozen or so very important objectives. Turns out there's an organization called the Center for Health Design that's been supporting research for the past several years in how to design hospitals to achieve those goals. In fact, our team reviewed 1,200 pieces of research done on how to accomplish those objectives that I mentioned. And we tested every design decision in the creation of the hospital against the evidence that was reflected in that research. So, and in fact, we're, as a member of that organization, we're committed to doing research on our new design and sharing that with our colleagues to make sure that just every time a hospital is built, it gets to benefit. We share that information, and everyone who follows us gets to benefit from the experience that we've had and the lessons we've learned.
I'm going to look forward to going to that medical center in
As a guest.
As a guest. No, please, just as a guest.
You'll come visit us.
I'll come visit you because I want to see all of this rational planning, all of this scientific thinking being applied to what probably hasn't been considered for, what, a century, 100 years or more.
It's a different way of planning healthcare.
Different way of thinking,
yes.
too, yeah. I'm very impressed. Thank you very much, Barry.
Thank you.
What we're going to do in the next show next month, I'm interviewing someone who's very interested and involved with prevention and feels concerned that people need to do more for themselves, need to do more to help themselves. And one of the questions he asked me is, why don't they? And so we're going to be talking about that next month. Other shows will be some students from a community college. I won't identify the college or the professor, but of course you're looking at her. Students who want to talk about what they want from college, what they need from college in 2009. And it's very interesting because they're saying things I haven't heard students say before. And down the road we'll have other guests. I'd like to focus on newspapers, local newspapers, and get some of the editors and publishers of our local newspapers to talk about why print journalism is still terribly important to our society. And down the road, we'll keep doing some interesting backstories. So I hope everyone can continue to join us. Thank you very much.